So how do we actually learn that there's an outbreak going on? Well, oftentimes it's reported from hospitals or clinics that are noticing an increase in the number of patients seeking care for a particular problem. The other way we learn about it is through surveillance systems. So there are two types of surveillance. One's active, one's passive. And active surveillance is a systematic, planned reporting of specific diseases and conditions by particular facilities or hospitals or healthcare systems. Passive surveillance is different. This is essentially voluntary reporting by healthcare facilities, healthcare providers for certain problems that they're detecting. Now, the CDC has the largest surveillance system. It's called the National Notifiable Diseases Surveillance System, and this works with over 57 local and state and territorial health departments who are required to report throughout their territories cases of a variety of different diseases. I've listed a few of the interesting ones here. So anytime there's a case of, say, botulism, that's reportable by requirement to CDC, and individuals at CDC are then evaluating and tracking what's being reported across the country. And that's another way that we learn about an outbreak occurring. So now I want to talk about the various steps in the investigation of an acute disease outbreak. So the first is to define the epidemic. Here we want to identify the cases involved, the overall population at risk, and if possible, any known control. So what a control would be is someone or a group of persons who were at risk at the same time as the cases, but who didn't develop the disease or the disorder. And they are useful, as I'll discuss later, in the ability to assess a level of risk of the disease among those who had among the cases versus the controls. At this point, we're also evaluating clinical features of the disorder or disease that for which there's this epidemic occurring. And along those lines, we're deciding whether or not this is a known disease or an unknown disease. So with the Zika microcephaly epidemic at that time wasn't a known disease, really, at least not in the way it was presenting clinically. So epidemiologists were at that same time trying to define the disease while they're noticing an outbreak. And this is done through a variety of approaches depending on the clinical presentation. And then at that point, it's also asked whether or not there's a known cause. And if there is a known cause, then that alleviates a lot of the next steps that I'll talk about. So the next step is to determine the time and the place. So who is getting the disease, where are they getting the disease, and when did they get the disease? And we're looking at relationships between these people in terms of their location, when they got the disease, to determine if what we're seeing is an outbreak of the same type in the same people, i.e. a cluster, or perhaps the disease is presenting itself in multiple different groups who are unrelated. If they're unrelated, then that will help us to better understand if we have a common source or a point source sort of spread. If people are not in the same vicinity in the same time, then we don't have a common source infection, for example. And if we know that there is a known exposure, so for example, an environmental catastrophe, that would be a known event, we can then use that data to calculate attack rates, meaning among those who were exposed, how many came down with the syndrome or the problem that we're studying. The next step would then be to develop a hypothesis using existing knowledge and analogy of diseases to the known etiology. And the next step, if possible, would be to test that hypothesis by further analyzing the existing data and, if possible, collecting more data if the epidemic is ongoing. And then the last step is to recommend or implement control measures to control the current outbreak and to prevent future outbreaks. So we talk about mitigation strategies to dealing with an outbreak. There's a need to balance between the need to reduce illness and death through social distancing, for example, if we're dealing with a disease that's spread from human to human, and to minimize social disruption as much as possible, such that the interventions to stop or reduce the severity of an outbreak shouldn't be worse than the disease of the outbreak itself. So during the Ebola outbreak, this was a balancing act for public health officials because, as we know, Ebola is spread from human to human contact, and in the countries where the outbreak was occurring, those cultures are known for being very physical and with each other. They hug a lot, they shake hands often, they're in they're close quarters. So for public health officials to go into those regions and tell people to stay apart from each other and separate was very difficult. So here's an example of a outbreak of a foodborne related illness. This is data from 1996, where there were 64 attendees to a luncheon, and of those, 39 people developed a diarrheal disease. So the first thing we can do is to calculate an attack rate, which is the number of those who developed the illness over the total number of persons who attended, otherwise known as exposed or at risk to becoming sick. And we get an attack rate of 61%, which is rather high. The next step would then be to further investigate what the people who attended this luncheon ate, and to calculate the attack rate by each food item. So here we are going to consider 3 different food items: ham, a potato salad, and raspberries. And we ask each person who ate those items whether or not they got sick, and among those people who didn't eat those items, how many got sick. And for each, we calculate the attack rates, and then we calculate what's called the relative risk, or risk ratio, which is the attack rates, or one attack rate over the other. So I'll quickly populate this table. So we get, for the ham eaters, the attack rate was 44% compared to 70% attack rate in those who didn't eat ham. And just initially, one would not deduce that ham was somehow protective. The next is a potato salad. 84 who ate it became sick compared to 48. So that's an item that falls out as a potential cause. And then similarly, the raspberries had an 89% versus 17%. But we're not done here. We next have to calculate the RRs, which is the ratio of the attack rates of those who ate the item over those who did not. And we're going to look at the one that's the highest, and that will ultimately be determined as the culprit of the foodborne illness. And in this case, it's the raspberries, with an attack rate a relative risk of 5.2. So we can conclude from that was the individual item that people ate that got them sick. Now, I want you to just know that for the homework that's part of Chapter 2, Question 2 and 3, I will want you to populate the table, just as I did in the past example. And this slide is just to alert you to that, and to hopefully remind you that detail needs to be done.